Thank you very much to give me a chance to present our work to this prestigious Congress meeting. This is my disclosure. As a less invasive treatment, thoracic endovascular aortic repair has emerged over the last decade. TIVR for descending aorta provides acceptable midterm outcomes. However, for aortic arch disease, some challenges are still remaining because aortic arch has angulated morphology and supraaortic branches. In Japan, a large number of patients have the aortic arch pathologies. So, the pre-curved fenestrated endograft was developed from early 2000s. The purpose of our investigation is to provide an appropriate proximal landing and to minimize operative complication risks. I will show you the latest information of our totally endovascular treatment for aortic arch disease using pre-curved fenestrated endograft. In Japan, we had already completed multi-center clinical trial and awaiting approval from the Japanese Ministry of Health, Labor, and Welfare. And this device has evolved continuously. From January 2010 to December 2011, 383 patients were treated with pre-curved fenestrated endograft. 44 patients had aortic dissection. Proximal ends of the region were mainly located in zone 2 and 1. For each patient, treatment length and aortic arch configuration was evaluated in 3D volume rendering window. According to these yellow and red lines, the endograft suitable for each patient are fabricated from three-dimensional curved stent skeleton and fenestrated multi-layered EPTFE graft. This device has 90 types of 3D curved stent skeleton and 8 types of graft fenestrations for arch vessels. In this case, complicated three-dimensional curved configurations were observed. Most twisted stent skeleton was selected for distal device. In this type of twisted formation, the proximal device landing from ascending aorta would rotate to anterior side. So, this device had fenestrations on the posterior side of greater curvature. Devices were implanted from distal side. In this case, TAG was implanted from the descending aorta previously. The distal device was placed just distal side of LCCA branching. As you see, the distal device did not fall into aneurysm without proximal landing. Then the proximal device could get good sealing for this type of large aneurysm. Post-operative CT shows complete exclusion of blood flow and good conformability to complicated angulation and, of course, preserving perfusion for supraaortic trunks. I will show you the basic deployment technique. This case had a typical tachyral aneurysm suitable for endovascular treatment with this device. This device has an original stabilizing system for exact deployment positioning in the aortic arch and the normal blood pressure. The proximal end of the device is gradually opening, and the second and third units of this stent are landed to the aortic wall first. The endograft is still able to be finely adjusted at this time. Device rotation was automatically controlled by a pre-curved shape of the stent graft and this stabilizing mechanism. Making good use of blood flow, the endograft can be pushed up to the greater curvatures to achieve good conformability, and the graft material is expanded to the proximal landing zone. From now on, I will present some implanting strategies for the patient with short proximal sealing zone. When the aneurysm has a large space in the greater curvature, we must control migration during deployment period. This style device, which had stent strut in greater curvature, was placed just distal side of LCCA branching. And then we could push up the second proximal one to the greater curvature and got a good sealing without migration. The patient has short proximal sealing zone with smaller curvature aneurysm. We need to push fenestrated unit up to the greater curvatures. TAG was implanted to make distal landing zone previously. Please watch the distal device. It has rigid stent skeleton in smaller curvatures. And then, the proximal device deployment was easy and stable. Fenestrated device was never fallen into aneurysm sac and got a good result. When the patient had descending TAA extended to aortic arch, we had to use more than 3 endografts. For this type of large aneurysm, the endograft should be placed along the greater curvature of the region to prevent long-term migration. In this patient, 2 pieces of TX2 were implanted previously. After that, the pre-curved devices could secure an appropriate proximal landing and demonstrated the conformability for greater curvature. The LSA revascularization was performed to prevent spinal cord ischemia. When the proximal landing zone has a reverse tapered shape, we have to make additional sealing zone. In this case, device diameter of distal stent graft was oversized to proximal 1. TAG was already implanted from the descending aorta, and distal device landed at the reverse tapered neck to extend proximal sealing zone. Finally, the proximal fenestrated device could extend proximal landing zone and secured proximal sealing. We can also make custom-made device for the patient unfit for open surgery. In this case, the reverse tapered fenestrated endograft was required. Although device design was complicated, deployment technique was simple. In this type of sacral aneurysm, there is no room for migration. So stent graft deployment was smooth and accurate, and the normal blood pressure. Device rotation was exactly controlled during deployment period, and we could get good results with short-time operation. I think the pre-curved fenestrated endograft is suitable for aortic dissection. For the type B dissection, this device can landing from healthy aorta with low radial force. As you can see, the deployment technique for dissection is quite easy. Pre-curved shape is fit for severely angled configurations. We are now waiting for long-term results. As you know, TAA with dissection is a high risk for rupture. 3 pieces of endograft were required for this patient. In this device, the EPTFE graft supported with inner stent skeleton without suture. That is an advantage to fit for deformed true lumen. This device does not have bared stent and valves, but proximal migration rate is rare because the stability of this device comes from the pre-curved shape. In this study, almost patients had endovascular treatment from zone 0. As a result, while most patients had inadequate proximal landing zone and severely angled complex configurations, low mortality and morbidity and satisfactory clinical success have been achieved at the initial stage of this study, and the short time required for operating and fluoroscopy. The anatomical indication with this device is not clearly determined. Some endoleaks was caused by human error, and of course, we need long-term follow-up to know what the best way to help our patient is. It has become possible to treat these types of aortic arch disease without open surgical approach. The totally endovascular procedure using a pre-curved fenestrated endograft simplified the catheter manipulation and decreasing the incidence of neurological complications. Rotation of the device were controlled by the pre-curved shape, and the fenestrations were automatically oriented toward supra-aortic trunks. The short operating time and fluoroscopic time proved this procedure does not need a complicated catheter technique. The high rate of clinical success demonstrates this endograft technique provides an appropriate proximal landing across the supra-aortic trunks and yields good conformability to aortic arch angulations. In addition, a dedicated stabilizing system provides precise endograft deployment without circulatory assistance and minimizes device contact between supra-aortic branch orifice and the ascending aortic wall. As a result, the acceptable clinical success and low incidence of stroke and early death have been achieved in early outcomes. Of course, long-term effectiveness was not determined in this early stage of the study. However, the earlier study using the previous generation of this device have been reported with acceptable midterm outcomes, and the results of Japanese multi-center clinical trial confirmed midterm feasibility with absence of proximal line migration and branch occlusion. The aim of surgical therapy for aortic pathologies is prevention of aneurysm rupture, and the aim of the endovascular approach is to make that surgery less invasive and safer. So, the aim of our investigation is not only to extend anatomical indications, but also to minimize operative risks and maintain the activity of daily life of our patients, because they can live as usual over some time without surgical intervention. In the near future in Japan, patients with serious comorbidities, especially for the elderly population, will be treated with this minimally invasive aortic repair technique, as will the patient with lower risk depending on anatomical indications. With constant development of the device and endograft implant strategies, this most simplified therapeutic method with pre-curved fenestrated endograft has the potential to become one of the standard therapies for the treatment of aortic arch disease. Thank you very much for your attention.